Good morning, everyone, and thank you, teachers, for because of your blessings, I'm here. And just I want to say only one thing. Sometimes I wonder why we are not following the protocols. I'm from Rohtak Medical College. Dr. Rathi ma'am was there, and then Madam Uma Rai, Madam Uma Goyal, and from PGI, I have so many people, and we were just taught beautifully the active management of third stage of labor, and we were not, allowed not to do these things. And I wonder, after so many years, we are still on the same page. Why you are not practicing? And we were just taught simple thing as an MBBS student in our labor ward training: just sit, let placenta come, don't pull. So we have not seen in our practices even the uterine inversions. So these are little things. I will open my topic. Ma'am Sadhna Gupta has already said, but I'm going to talk about the carbitocin and prevention of PPH. So maternal mortality has definitely come down in India from 103 per 100,000 live births to 97, and the least in Kerala and maximum in Madhya Pradesh. So it's a big burden, not only to the woman, to her life, to her emotional and physical health, but it's whole her family which revolves around. And क्या हो गया? So it's very important that all the hospitals should have the set protocols for not only the management of PPH, but it's also for the active management of PPH. In our hospital, we have started that in all the notes, you will write active management of PPH is done how? 1, 2, 3. So that's why everybody remembers. And once we start the delivery of the patient, we make sure the uterotonic agent is ready for the active management of. So the practice of prophylaxis of PPH is very important. One, it starts from the antenatal care. Keep the hemoglobin more than 11. Identify the high-risk woman, but be prepared. It can happen in any woman unexpectedly. There's a strict vigilance in the third stage of labor. Have active management in all women. Examine your patient after the delivery. If you have a difficult delivery or an instrumental delivery, always explore the vagina and the cervix, and always do PVPR. It's very important not only to look into any kind of an anal sphincter injury, it's another very important to see whether you have made some hole or not, or there is some hematoma which is coming up. Another practice which all of us in bigger setups and even in the government hospital, there's always a postpartum ward. We have never shifted our patient before 2 hours to the ward unless this patient is seen for the vitals. And we have picked up so many atonic PPH even in the vulval hematomas because patient was seen in postpartum ward. So that's another very important thing. So I'm going to just talk again about the FIGO recommendations in 2022 that the use of uterotonic to be done in all women for the active management of the third stage of labor. Oxytocin 10 units intravenous or intravascular is still the first choice for the prevention of PPH after a vaginal delivery and a cesarean section. But the most important thing to say is that the cold chain is maintained properly. In the settings where oxytocin is unavailable or the quality is not granted, you can have ergometrin, you can have oral mesoprostol, which is very easy to give, very easy to store, which is 400 to 600 microgram orally. Carbidocin 100 microgram IV or IM, but whenever you give IV, it should be diluted and give over 1 minute. And we are all changed to carbitocin from till it's being launched, and we are very happy with the use of this. Combination can be given, but you must remember that the chances of side effects are very high. Like, patient suddenly blood pressure increases, there's a nausea, vomiting, fever, diarrhea. If you combine with mesoprostol, so better it should be avoided. Controlled contraction, it's already been discussed. So just wait, see the sign of placental separation, and only then you do the controlled contraction. Postpartum, patient should be examined as already discussed, and oxytocin should be given as a prevention for active management of third stage of labor after the cesarean section also. So in the low resource settings where the skilled birth attendants are not available, there or they can't give IV oxytocin or carbetocin, just give oral mesoprostol 400 to 600 microgram orally, and don't perform controlled cord traction. Let the placenta separate and then take it out. Otherwise, with the unskilled worker over there, the chances of uterine inversion are very high, and there is a high morbidity and mortality related to it. Uterine massage is not recommended as an intervention for prevention of PPH once the uterotonics are given. So expected management we are not doing nowadays because of the increased length of third stage and more blood loss. So just an overview for the uterotonics. Most effective component of active management of third stage of labor can reduce the risk of PPH by 40%, and in turn the risk of postpartum anemia also decreases. The routine prophylactics is recommended for all patients. Choice of uterotonic depends upon the stability, efficacy, safety, and the cold chain availability. Carbetocin is a long-acting oxytocin agonist with a half-life of 40 minutes, same as oxytocin, but the duration of uterine activity is longer. The mechanism of action has lesser side effects. Carbetocin has the efficacy and safety profile to oxytocin, but carbetocin reduces the need for uterotonic intervention and uterine massage, reduces the need of additional uterotonics, has more women experiencing blood loss less than 500. Compared to symptometrin or compared to a combination of oxytocin plus meso, it definitely has less side effects. So most of the guidelines, they choose oxytocin as the first line of management for the active management of third stage of labor, but they all give an option of carbetocin also. So carbetocin was created by making several modifications in the oxytocin structure so that it can prolong its life and reduces the enzymatic degradation. It's given only for the prevention of postpartum hemorrhage, only single dose, not for the treatment of PPH. Once PPH sets in, you have to use other uterotonic agents. So this is the mechanism of action. The carbetocin binds to the receptor, triggers the release, triggers IP3 and diacylglycerol, and then it releases the calcium from the cells, which binds with the calmolidine and leads to the uterine contractions. So how you differentiate, why carbetocin is better? Because it's stable at room temperature. Half shelf life is for 24 months at 30 degree and 70% humidity, avoids need of cold chain storage and its logistics. It's provided in a vial, whereas oxytocin needs a cold chain storage. And of course, carbetocin is more expensive as compared to the oxytocin. But there is a study done in UK which says that if a woman has a PPH, the cost of the uterotonics plus cost of the investigations, blood transfusion of the blood products, IV fluid, stays in ICU, and the mental health later on is definitely far more than using carbetocin as active management of third stage labor. So I think that's very important. Cost is very important in our country. But if a woman has a PPH with so much of morbidity, mortality related to it, it's worth trying it. So we wish that companies, they decrease their price and it comes to the government setup also. So here you compare that the benefits of heat stable carbetocin I have already discussed. And if you compare the IV and intramuscular, one can see that the oxytocin, if you give intramuscular, the onset of action is same, but with an IV, there is it's an immediate action with an oxytocin, but after 1.2 minutes, the carbetocin action starts, but the duration of action is prolonged, which is more with intramuscular carbetocin, which is 119, and 60 minutes with IV. So that is very beneficial for a woman in prevention. And with carbetocin, the chances of hyponatremia and water intoxication is also less. Champion trial, they have already discussed that this is not inferior to oxytocin. And carbetocin, when used versus oxytocin in a non-elective cesarean section, found to be that it favors the use in a cesarean section. And its carbetocin has definitely less blood loss and more hemoglobin where it's used for high-risk vaginal deliveries. So key take-home messages is it's significant. PPH we all know is a significant cause of a maternal morbidity and mortality, and active management of the third stage should be done in all the cases. It should be an institutional delivery, and everybody should do active management of third stage of labor to prevent. We should work on a prevention of PPH, single dose of carbetocin IV or IM to be given, or you give oxytocin 10 international units IV or IM. But the most important thing is wait for the sign, placental separation signs to be there. Only then you do controlled contraction. In a low resource setting where there is nobody to give IV oxytocin, then mesoprost 400 to 600 microgram to be given orally. And it's so nice to see that in the morning whole house is full. So we are all basically working towards the prevention of PPH. I hope one day come when we don't talk about prevention and we go a little more forward about it. Thank you.